Well, all right. Welcome everyone to our session today on improving patient safety culture. We are glad you could join us. Let's get started. I can go to the next slide. Please note that the recording today will be available on the National Action Alliance website. You can also use the chat function to engage with us and ask questions, and also closed caption is also available. Next slide. We encourage all interested healthcare systems to visit the National Action Alliance website to understand the commitment process for this, which involves having an executive leader in safety pledge on behalf of their organization. Organizations can formalize their commitment by submitting it via email to nationalactionalliance@hhs.gov. We can go to the next slide. Today is part 2 of a 3-part series on establishing and maintaining safety culture. Last month was a great session on psychological safety. You can get that recording on the National Action Alliance website. Next month is on measuring and responding to safety culture, which is much more interesting than it sounds. But today we are talking about the 2 most storied and enduring components of patient safety culture: the teamwork norms in a work setting near you and the patient safety norms in a work setting near you, and how to improve them. Next slide. What we know is that culture is local. Your work setting culture impacts your behavior, and your behavior impacts your local work setting culture. It's just the way we do things kind of around here. Your safety culture isn't words on a website or posters on a wall. It's how your people feel on a Sunday night before they get ready to go in the next day. So regardless of your strategy or intentions in any given work setting, your culture eats strategy for lunch. It's the norms of the way we do things around here that drive so much of our behavior. Next slide. So unlike employee engagement surveys or physician well-being surveys, the core of safety culture is in this work setting. How do we interact with each other? That's kind of teamwork norms and behaviors. And what are the patient safety norms that drive behaviors related to patient safety and quality in this work setting? We assess safety culture at the work setting level. That's important to recognize because there's actually 5 times more variability between work settings in the average US hospital than there is between hospitals on average. So culture is very local and change is very local. That's where you assess, that's where you debrief, and that's where you do action planning. And the 2 wonderful ways of going about doing this, which you're going to hear about today, are using TeamSTEPPS to address teamwork norms and using CUSP to address patient safety norms. Next slide. The themes to consider as we introduce our speakers today are what are some effective teamwork methods to promote a culture of safety, and what are some specific tools and strategies that you can use to improve kind of safety climate, patient safety norms and behaviors. So with that, I would like to introduce our first speaker. It's my pleasure and privilege to introduce to you my friend and colleague, Dr. Kyle Rader. He is the Section Chief for Pediatric Intensive Care at Duke Children's Hospital and Vice Chair of Education in the Department of Pediatrics. In addition to his clinical interests in mechanical ventilation, airway management, and ECMO, he also serves as the Medical Director for Professional Development at the Duke Center for Healthcare Safety and Quality, where he teaches extensively and coaches teams about many different aspects of safety culture, including teamwork and communication, professionalism, psychological safety, and well-being. With that, let me hand it over to Dr. Kyle Rader. Kyle?
Thank you so much, Brian. Thanks to all of you who joined us today. Very excited to be here. Privileged to talk on this topic. Always excited to talk about this topic because I think it's such a huge impact on how we care for patients and actually how we care for each other, interact with each other, and build job satisfaction in what we do. So we can go on to the next slide. So as we're going to talk about, we talk about how teamwork matters is the first thing I want you to remember. And I'm sure I don't have to convince any of you of this, that teamwork matters. But if we think about teamwork climate, how we assess and measure teamwork. It has strong associations to all the things here, in addition to multiple others. And there's, in each of the ones I've shown here, there's multiple studies that I could reference, and there's some later that we show in terms of references, but it affects how the hospital runs. It affects how we interact with each other. It affects our patients' experience. It affects our staff and their willingness to stay with us, and all those things that we follow in terms of our quality and safety metric. So if we move on to our next slide as well. So what, it's common sense that this matters. But one of the things I want to say is that this is long known, but it still very much holds true today. And so one of the more recent examples, we looked at a health system and said, I wonder what happens if we track teamwork over the course of the pandemic. And so this was a large health system with several hospitals and hundreds of clinical work settings. And we looked at the work setting level within a team, what happened to teamwork over the course of the pandemic. And what you can see is that if teamwork improved, which is the light gray bar here, everything else improved as well. And those were the only units where burnout over the course of the pandemic, when we were so stressed, maintained and at least did not get significantly worse. However, if teamwork fell apart, which is the dark bar here, everything fell apart. And so we could track this over the course of the pandemic, and it had such a huge impact and strong association with every other aspect of our care. How were we able to adapt to all these new things that kept coming our way? How were we taking care of each other? Were we speaking up with concerns? And we'll talk about psychological safety. I know you heard about that last week. So we can go to the next slide. Another area, this is some unpublished Duke data, and we looked across our health system with one of our last big culture surveys, and we said, what were the questions that were most closely associated with our healthcare worker well-being? And these four really jumped out at me. So if I perceive a problem with quality, it's difficult to speak up in my work unit. The person I report to creates an environment of trust. My ideas and suggestions are seriously considered by the person I report to, or in this setting, it's easy to discuss errors. And so we see these themes come up in terms of, I am able to perform my job better if I have voice, if I have some control, if I have trust with my colleagues and my leaders, and I feel supported and given feedback. And so all of these things are at the heart of the teamwork work that we're going to talk about today. So if we can go to the next slide. This is where we often live in healthcare, is this image on the left. We have a lot of expertise at the table, but that doesn't necessarily mean that we're all working together and working in the same way and supporting each other. And so can we move from this page of a team of experts to the image on the right, where we truly have an expert team that's working together to accomplish a task? And then that brings up the next question, which is, does team training improve outcomes? Can we actually make a difference? And so at the heart, I believe that teamwork is not an innate skill. We all have those folks that we work with that we think of, oh, they're just naturally a good team member. But the point is they've learned it somewhere, and we can teach these skills to other people. So this is a systematic review and meta-analysis looking at team training across, you can see many studies here, and you can see the forest plot at the bottom shows that generally the outcomes do favor team training. Now, not in every case, and there was plenty of studies where it was a neutral result, but you can certainly see that trend. And it also speaks to team training works when we do it well, like anything else. And we can also do team training events that maybe don't have the impact we want. And is it the problem with the training itself, or was how it was implemented? And so we'll talk about some tips in terms of that. We can move forward to the next slide. And so this brings us to what our main focus today, which is TeamSTEPPS. And TeamSTEPPS is by far one of the longest standing, best proven ways to train our teams within healthcare. So many of you are familiar with this. You've seen some version of it. It's the team strategies and tools to enhance performance and patient safety. Initially came kind of out with the support of AHRQ around 2006, adapted from military and aviation, other places where we can see people, organizations transition to high reliability organizations, and using teamwork as a big aspect of that. The thing that I love about TeamSTEPPS, it is both evidence-based, but highly adaptable to any setting. We've done this in just about every work setting within the hospital. We've done it with non-clinical teams as well. And in fact, a lot of the same tools I use in my family, and they work really well. Most recently, I'll say, just a couple of years ago, we partnered with AHRQ, and AHRQ pulled together a panel of experts around the country and did TeamSTEPPS 3.0. And so some updates. And so made it more patient focused, made it more modular and active learning so that as we bring out this training, we're meeting the needs of people where they are, making it even more adaptable. And how do we adapt for some of these emerging technologies and challenges? The way we communicate has changed. The multi-generational workforce is a new challenge. And so TeamSTEPPS 3.0 starts to address that in some ways that we haven't before. We can go on to that next slide. And so does it matter? I mentioned earlier, team training can change outcomes. These are all studies and outcomes that have been specifically tied to TeamSTEPPS. And we can see multiple layers of the way that it changes how we work, how we perform. We can see that it changed people's behaviors in terms of just going out and watching how people interact with each other, how they interact with patients. Do they speak up with concerns? Do we have less errors in our daily work? Culture, as Brian spoke to, culture eats policy for breakfast. Can we actually make a change in culture? And so as you know, this is the middle one here is from Northwell Health, where they did a system-wide implementation. They said everyone in our entire system is getting trained in TeamSTEPPS. This is the way we're going to do things now. And they saw pretty significant improvements across the board in safety, organizational learning, staffing, how they respond to errors, all of those things. And then finally, the things that matter to our patients: reduction in falls, supply chain, improvement in OR start time, unplanned operations, critical bleeding after surgery. All of these things we've seen improvements using TeamSTEPPS. We can go to that next slide. So what are those core tools of TeamSTEPPS? Again, the highlight is this is not something that people have as innate knowledge. These are teachable, learnable skills, and we focus on those 4 skills of communication, leadership, situation monitoring, and mutual support. Within each of those skills are specific, very practical tools that you can use, and it's on the next couple slides that I'm going to dive into that. So the first of these I want to highlight is thinking very carefully about how we structure our language during key times of critical communication. And that can be handoffs. That can be the moment which we're trying to escalate a concern using SBAR. Many of you are familiar with SBAR. That's how we can raise our concern and ask for a request or recommendation within a very succinct communication format and context. And we know that when we structure our language, that the information that we pass on is more accurate, we have less omissions, we have less errors, and it makes it more efficient. We can transfer more information in a shorter period of time. And that structure not only helps the deliverer of information, it also helps the receiver of information, because they know when they're going to get key pieces of information and they have a better understanding of what's being asked of them. So multiple places where we can use that. SBAR is one I highlighted. We're going to talk about huddles a little bit, but also patient handoffs and rounds. So we go to the next slide. We will dive into thinking about briefings and huddles. So this is another key tool that I'm sure you're using already, but I might challenge you to say, how can we use our huddles better? How can we use our briefings better? So a briefing can be anytime that you gather the team before you set upon a task. It can be the first thing in the day. You may call that a huddle. In our parlance, we call that a briefing. It may be before an OR case or a procedure where we do a timeout and we pull the team together. But the key question is everyone on the team have a shared mental model of what we're going to do today? What's plan A? Potentially what's plan B if something goes wrong? Do we have that opportunity to ask questions and share key information? Because every single team member may have different information to bring forward. And so last webinar, you heard about psychological safety. This is a great place to establish psychological safety, to start to bring out that information, bring out concerns so that we can get those addressed beforehand. And then finally, we can turn around and establish role clarity. Who's doing what on this task so that we have a clear plan moving forward. Let's move next. So another key tool that we see people really lean into heavily as we go into TeamSTEPPS is critical language. And so some of you know this as the CUSP language, but broadly thinking, critical language is teaching someone how to speak up. Think about that brand new nurse, right, on orientation. How do they speak up to the attending when they have a concern? What are the words that they need to use? There's lots of reasons that they may not speak up to the attending physician. They may not speak up to that charge nurse, that senior nurse. There's hierarchy. There's fear of the relationship and the rebellion. Sometimes they don't want to step on toes. But if we don't speak up, we know that errors happen. And we have to keep in mind that this is about what's right for the patient, not who's right, but are we doing the right thing for the patient? So this is an advocacy tool. And so going back to that CUSP language, what TeamSTEPPS teaches, and this is the most commonly used across the country, is that CUSP language. And it's a escalation in a stepwise fashion. I have a concern, so I'm going to say, I am concerned about X, Y, or Z. And if that person still doesn't hear you, now you're going to escalate to the next phrasing, which is, I am uncomfortable. And then finally, stop. This is a safety issue. Stop the line before an error happens. And so this escalation allows people to find the words. And ideally, you want to make sure everyone on the team knows those words. So if someone walks up to me on my team and says, hey, I'm concerned about this, it's the same thing as if my spouse or my partner walked up to me and said, hey, we need to talk. And I don't ignore that. I say, whoa, okay, let's figure out what's going on so we can make sure to correct this before we make an error. And I have several instances where I can think of where someone else used CUSP language with me that helped me prevent me from making an error, whether it be a wrong med dose, a mistake, something else like that. So teaching people that language, not only to know the words to use, but empowering them to speak up. All right, we can go to the next slide. And so the next tool I'm going to talk about, and the last tool I'm going to talk about today, is the idea of debriefing. So we've done the task. Do we actually take that time to pull the team together to talk about it and learn from it? So I know many of you have probably been to a debrief when something went wrong. What I'm going to challenge you as, have you done a debrief when things went well? Have you learned from what went right in the same way that you've learned from what we could do better next time? Whatever setting, if you can build debriefing in as a regular practice, we know that leads to better outcomes, whether it be in the ICU or the OR or the clinic. If this is something we do regularly, that's how we continuously improve, and we get a little bit better tomorrow than we were today. And even more importantly, again, psychological safety, getting people in the habit of speaking up. We know that teams that debrief regularly are more likely to speak up with concerns outside of that debrief, because it's part of our normal practice to speak up. And you're really taking advantage of all the minds that you have, all the expertise that you have in that team, to give people a chance to share ideas and other things like that. So really encourage you to think about using debrief, not just when something goes wrong, but as a part of your regular practice. So with that, as we think about going on a TeamSTEPPS, we can go to the next slide and we'll talk about what are some of those general implementation tips. So those are just a few tools that I showed you, whether it be structured language or critical language, debriefs, huddles, and briefs. But there's other tools in the suite. So if we wanted to take on TeamSTEPPS in our team or our organization, do we do just one of those, or do we try to do all of the tools together? And generally, we really try to think about doing this, in a stepwise fashion. Your team can only take on so much as one time. So you really want to understand where are the gaps I'm trying to address, and choose some of those tools that are really going to help address that gap. Not just address that gap, not just necessarily one tool at a time, but at least targeted towards those gaps. Make some improvements, celebrate the wins, and then come back and revisit and say, what's that next tool that we're now going to bring in? You also do want to understand, is your team ready to change? Do we need to address other things in leadership or burnout before we really take on this adding one new thing? But hopefully, if we can improve our teamwork, we'll find that the team will be more efficient, they'll be more adaptable, they'll actually continue to improve and be able to take on new things in the future. It's important to understand that change takes time, and to use really good change management principles to help bring your team along with you as you start to make this change, to help them support the grief that they're going to have from losing maybe their old way of doing things, or other things like that. And then as you move into, hey, we've made some really good changes. Can we sustain this? Thinking about ways that you want to very purposely hardwire those tools, so that it's not just reminding people to behave a certain way, but it's really structuring their standard daily work so that they're using these tools consistently every time. So with that, I will wrap up and make sure that we have time for questions, and also time to hear from Pat.
Thank you so much, Kyle. I don't think I've ever seen TeamSTEPPS as broad and sweeping as it is, introduced so quickly and so efficiently. We will come back to some TeamSTEPPS related questions in the Q&A. But real quick, let me go to the next slide and go ahead and introduce our next speaker. Thank you so much, Kyle. Next is Pat Posa. Pat is the Quality and Safety Program Manager for the Hospital Medicine Safety Consortium, providing clinical oversight for the quality improvement work. In over 45 years of practice, including roles as manager, director, and administrator, she has led initiatives to reduce hospital-acquired infections, improve patient outcomes, and reduce readmissions. Pat's experience with CUSP, which she will introduce to us all today, extends all the way back to the very first statewide collaborative through the Michigan Health and Hospital Association. I was there. I know she was there. But it has grown far beyond just eliminating central line associated bloodstream infections. Please welcome Pat to the session. Thank you, Pat.
Well, thank you, Brian, and thanks for that nice introduction. And I appreciate the invitation to be here today to talk about strategies to improve safety culture. So let's get started. So as Brian talked about, I was part of the first statewide collaborative where we focused in the state of Michigan, the Michigan Keystone ICU project, on improving both culture and prevention of errors and harm in our ICUs. And the program we used was CUSP, which is the Comprehensive Unit-Based Safety Program, and used to improve our safety culture. So as just shared, this was a collaborative effort between AHRQ and state and national level innovators. And it works very well with other quality improvement tools. As you heard Brian say and Kyle say, and then last month in the webinar, culture is local, and this comprehensive unit safety program takes that into account. And to improve culture, it must be improved at the unit level and owned by the unit level, and that's what CUSP provides for us. It also focuses on that harm is not the cost of doing business. We can prevent harm, and you can apply it anywhere to anyone in inpatient unit, outpatient unit, ambulatory, surgery, etc. So let's go to the next slide. So what are the components of CUSP? So there are 5 components. The first one, educate on the science of safety. The second is identify defects. And one of those strategies to identify defects is through a staff safety assessment, and I'll talk about that in a second. Important to have senior executive partnerships. And then the 2 final components of the CUSP program is learn from defects. So those defects you've identified, how do you learn from them? And then how do you implement teamwork and communication tools? And a lot of those are some of the tools that you've heard Kyle talk about, but I'm going to talk about 2 different ones. So let's go ahead to the next slide. So at the organization, one of the hospitals in Michigan that I was working at, we started this work by creating a multidisciplinary team. So we had 3 ICUs involved. We had the medical directors of each unit, nurse managers, clinical nurse leaders, bedside RNs, respiratory therapists. So everyone that's involved in caring for the patient were part of our team, pharmacy, nutrition, PT, and OT. We began by administering a culture of safety assessment. So at that time, we used the SAQ and then moved to the HSOPs. And we started off by educating the team on the science of safety. And there is a science behind safety, and this was put into orientation. So everyone was educated on this. And then we started our journey by asking the frontline staff 2 questions, and this was that focus on identifying defects. So how do you think the next patient will be harmed? And making sure that we focus on preoccupation with failure, right? So how will the next patient be harmed? And then deferring to the expertise of the frontline staff. What can you do to prevent that harm? Those were two key questions. They also began to help with psychological safety, that we wanted to hear what you were concerned about, how you think harm could happen. And these questions became part of our executive safety rounds. Go ahead to the next slide. The next step was to be able to focus on learning from our defects. And so go ahead to the next slide. So what's a defect? Well, a defect is anything that you don't want to happen again. So go on to the next slide. So that can be a whole host of things, right? And we know that we can learn so much from errors. Errors provide useful information. We learn more from errors than from our successes. We find hidden causes, trends. We find out how we can reduce risk. As Pareto said, give me a fruitful air anytime full of seeds, bursting with its own corrections, and you keep your sterile truth to yourself. So really, by looking at our defects, we can learn what needs to be improved in our processes. So go on to the next slide. So what is learn from a defect? Well, it's a tool that helps you rigorously analyze the components and the conditions that contributed to that adverse event or that defect. And by dealing with it and analyzing it, and learning from it, you're likely to be successful in eliminating it from occurring again. And so when you're learning from this defect, this tool helps you organize factors that might be causing the defect from happening, looking at system factors, et cetera, looking at patient, team, task, and caregiver factors, education factors, technology, what in the environment might be impacting it, so local or institutional factors. So go on to the next slide. So this is the learn from a defect process. It's not complex. It will sound very familiar as I go through it with you. The first step is what happened? And this is from the viewpoint of the people involved in the error happening. So what happened? And then why did it happen? So what is the system? What's the process breakdowns? What might be causing this? So what is that root cause of why this happened? Then identifying what the whys, how will I reduce it from happening again? So what interventions can I put in place to, based on what I know about why it happened, that will reduce it from happening again? And then how do you know the risk is being reduced? So how do I know if my interventions are really going to prevent this harm from happening again? And then with whom will I share the learnings? And a very important last step, because we know that culture is unit-based. Culture is something that happens individually in places, but we can learn what is happening, and what happens in one unit might also happen in another. And so it's important to identify who you're going to share these learnings with, so that you can prevent those same defects or errors in another place. So go on to the next slide. So we applied this to and used it for evaluating hospital-acquired conditions. So an example here you see on the screen, learned from a defect related to CLABSI. So we had a standardized document that people then could follow. It was still going through those 5 steps. What happened? Why did it happen? But we wanted to have some specific questions asked, and then finalized with an action plan once the what happened to cause this defect was defined, action plans to mitigate that risk, and then how are you going to share the learning. On the next slide is another example of you can use the learn from a defect to deal with adverse events that are reported. Here's an example of a central line placement where the guide wire was lost. And so the team went through what happened, why did it happen, and developed an action plan to reduce the risk based on what they found was the root cause of why this happened. So next slide. So it's important to standardize how you approach and integrate that learning from a defect into your culture. And it became part of our culture. If error happened, someone on the team would just say, well, we probably should do an LFD on that. We should probably learn from that defect. And we created badge cards to assist and make it easy for the team to know those 5 steps and give some resources to them. So teams would, in the moment, learn from a defect. We started expecting people to do this once a month. You know, make sure that you were learning from error that or an issue, the defect that occurred on your unit each month. We also use that learn from a defect to respond to the staff's response to how will the next patient be harmed. And this really helped improve that psychological safety and our culture because the team spoke up. We wanted them to speak up. We're asking you, you know, how will the next patient get harmed? We're asking you to report your concerns. And then we did something about it. The last thing that is helpful and the first thing to knock down psychological safety is for people to report issues and never hear and they go into a black hole and they never hear anything about it. So by applying the learn from a defect to those error reports as well as to the when the staff responded to how will the next patient get harmed, it showed the staff that, okay, they heard, they listened, and we helped and problem solved together to solve this concern. So it became an expectation that this was after every hospital acquired condition. In a post-fall huddle, we used it as well as with skin injury. So that's it on learn from a defect. And let's go to the next slide. I want to talk about teamwork and communication tools. You heard from Kyle, and what's available in TeamSTEPPS are a whole host of teamwork and communication tools that are an important part of improving the culture of safety. I'd like to focus on daily rounds, so interdisciplinary rounds with daily goals, and talk about that. As you heard about briefings and huddles from Brian. So let's go on to the next slide. So what are interdisciplinary rounds with daily goals? It's a strategy to assemble the team together, review important patient care and safety issues, and improve collaboration and get input for that plan of care. So overall, what will happen when you do interdisciplinary rounds is you're going to improve communication amongst the care team and the patient and family. When you establish goals, they must be specific and measurable and documented where everyone has access to it. Checklists are often used during rounds, and it helps caregivers focus on what needs to be accomplished and how do we get ready to and prepare this patient to be transferred out of the ICU or discharged. It's important to measure the effectiveness of rounds. And so after we implemented this, I audited, and other people as well had an audit tool, and we audited how did the rounds go. Did everyone do what they were supposed to do? How were the team dynamics? Was communication open? Did people shut each other down? And then we also looked at its impact on our safety culture survey questions of I feel comfortable speaking up, as well as I feel there's good teamwork on this unit, showed improvement as we put in interdisciplinary rounds. So what does the literature say? So go on to the next slide. Research shows that there has been impact on certain things when you put in interdisciplinary rounds. Early identification of clinical issues, reduced adverse events, more timely referrals, but most importantly, the ratings by nurses and physicians improved on teamwork, communication, and collaboration. Variable impact on length of stay and cost. Some studies showing improvements, others having no impact. So how do you do this? Go on to the next slide. Well, it can be challenging, but we should do it in all of our units, both in the ICUs, and you're typically going to see good interdisciplinary rounds in ICUs, but not always. But it should be something that's in all places on in the hospital. It's harder to implement when you have open units in the ICU and in the non-ICU areas. If you have multiple teams on this running the floor, you have multiple teams on the same floor. But you need to standardize the structure and process. And so who attends it and what is the role of each person and there's a script for each person on rounds. And then how do you define the plan of care, who's defining it, and then the goals for the day, and where is that going to be documented? There is some benefit, even if a physician cannot attend, if you have a structured script. If they can't attend every day, that's okay. Especially on the floor, not the case in the ICU. It's very important for the physician to be there. A lot of institutions have put in a second round done in the afternoon. It's recommended. And here with at least a physician and a bedside nurse, and really here you're evaluating. So have we met our goals? And do we need to readjust them? And can we get this patient ready for transfer or discharge? What else needs to be done? So go on to the next slide. You'll see here that in establishing and standardizing your rounds, as I said before, you first focus on who should attend and what's discussed and by whom, and making sure that it's in a good timely fashion, right? So it doesn't last forever. Interdisciplinary rounds are important to be succinct, and you have to find that balance, especially in a teaching hospital with teaching rounds. We first focused on defining what the daily goals and who would record those, and then we did standardize each person's role in and developed a script for each person. You can see on the right-hand side, this was our script for the nursing staff. It was put into a badge card. Love badge cards, right? Everyone walked around with their badges pretty heavy because they had so many badge cards on them. But here, this was the ability also to have independent checks for key practices that should be occurring in the ICU. We incorporated the A through F bundle here, sepsis, hospital-acquired condition prevention, lines and tubes, etc. And then just general any nursing concerns and family, who's going to talk to the family today if the family wasn't available on rounds, etc. So standardizing it, and when would the nurse be speaking in rounds? And it worked best to position them right after the overview of the patient and the overview of the last 24 hours before the system assessment by providers, so that everyone was attentive and listening to what they had to say. So go ahead, next slide. So these are two tools that can help improve your patient safety culture. And next steps for you, if you really look at, do you have any gaps in strategies to improve your safety culture? Do you have a structure or process in place to identify defects and learn from them in real time, as well as longitudinally? And do you have any processes in place? Have you put in any of the TeamSTEPPS? Have you put in interdisciplinary rounds, things that will foster teamwork and improve communication? I want to thank you guys for your time and attention, and I'm going to turn it back over to Brian, and he's going to lead us on to some questions.
Thank you so much, Pat. I can't wait to get some of the questions that are already coming through when we do Q&A. Just as a quick reminder, I want to let you know that in the chat we put a link for if you want to get involved with AHRQ CUSP efforts. You can check out that link for more information and to enroll. Go ahead and go to the next slide. What I want to share with you is a quick word on CUSP and opportunities for you to engage directly with leading CUSP experts to do work in your work settings. AHRQ is running national implementation projects to prevent hospital-acquired infections and deal with antibiotic-resistant bacteria. Using CUSP methodology, these programs improve teamwork norms and use checklists and toolkits to promote best practices and improve patient safety. You can get guidance from clinical experts, and resources are posted on the AHRQ website. You can go to the next slide. Some cool examples of AHRQ success stories. These are impressive. They've shown substantial decreases in central line associated bloodstream infections, CAUTIs, surgical site infections, and antibiotic use. Next slide. Now, the preliminary results from the ICU and non-ICU cohorts show significant reductions in hospital onset MRSA bacteremia, MRSA positive cultures on or after hospital day 4, and bacteremia due to any organism, and central line associated bloodstream infections. So high risk surgical services include cardiac, knee and hip joint replacement, and spinal fusion. You can go to the next slide. Ongoing AHRQ CUSP efforts include improving antibiotic use in telemedicine environments. You can learn more about this and the toolkit being developed by visiting the AHRQ website. Next slide. And if you are interested in getting involved, please do. The link is in the chat. AHRQ is enrolling hospital units, ICUs and non-ICUs for HAI prevention. That is a quick overview of some of these excellent CUSP opportunities in terms of working with and through AHRQ. Let me turn to our AHRQ CUSP leads, Melissa and Dave, and ask if there's anything they want to add to this admittedly very brief overview before we move on to the full Q&A. Would you add anything to what you've heard presented so far?
Nothing to add from me, Brian. That was great, but we're definitely here if there are any questions.
Well, excellent. Well, then we will go ahead and go on to the next slide and open it up for Q&A. We have our AHRQ CUSP experts. We have our TeamSTEPPS speaker today, Kyle, and we have Pat Posa on as well. There are a lot of questions have already come through the chat. And I'm going to try to keep up with the chat's moving fast and furious here. If I can start with Kyle, if you don't mind me starting with you, there's a couple of things here. Some of it you've already addressed, but I wanted to add, just point this out. First to Kyle and then to Pat. Kyle, given your experience, because I've watched you do this at Duke for a long time, given your experience, is there a do you have a favorite, like go-to TeamSTEPPS tool that you feel is like pretty, universally applicable as you go across different work settings for getting people on board and kind of building momentum?
Yeah, I think the huddle is such a good one to do. I'm such a big believer in that interprofessional communication and pulling people in. I think a lot of people will start with SBAR, which I think can be great, but getting people to talk to each other in that huddle, debrief can do the same, but the huddle it feels preventative. It feels like if we can talk beforehand, we can prevent that error from happening. We can make sure we're all on the same page. The resistance to a huddle is that we are super busy. We are, we don't have time to stop and do a huddle or talk. But what we see consistently is, and by definition, and whether you want to call it huddle or briefing, taking that moment to regroup, get everyone on the same page, you'll make that time up in efficiency without fail. And so, the huddle and briefing really go side by side in terms of what they do. And so huddles and briefs together, I think, is my number one tool.
Yeah, huddles and briefs kind of on the ounce of prevention side, debriefs on how do we prevent recurrence kind of. Yeah,
the continuous learning is where debrief is about.
That's great. Thank you so much, Kyle. Pat, real quick, if you don't mind me just asking you the same thing, do you have a go-to component of CUSP that you felt was really helped with buy-in or helped to get things launched, or it was a good starting point for work settings trying to do this kind of admittedly difficult work?
Well, there are so many good tools, and I think to improve the psychological safety, it's really and you guys talked about this at the last webinar, it's the leader rounds right? Where they're asking the staff, how will the next patient be harmed? And then doing something about it, right? So, and then applying that learn from a defect. I think that learn from a defect is a game changer, right? To where you're really, you're showing the staff that you're hearing, and then you're doing something about it to help prevent it from happening again. And having that just be part of this is how we do work. When something happens, oh, we should do an LFD on that. We should learn from that. I think that that was a significant tool to change the culture of, okay, we're going to talk about errors because we want to get them better. We want to improve them.
Having watched this play out in so many different work settings that are trying to roll out CUSP, learning from defects is my favorite. Absolutely, just because it's so agnostic to, is it a clinical issue? Is it an operational issue? Is it something we don't even understand yet? That the learning from defects has this component baked in that comes from Jim Reason's research, the British psychologist, which is called the substitution rule, which is if we were to take the people involved in this defect out of the equation and replace them with some random other person, could this thing happen again? And if it could happen again, then we haven't yet fixed the system. And that little learning, that little aspect of learning, light bulbs would go on people's heads, and I would just watch it transform people's engagement with the whole process. So learning from defects and the substitution rule, and really understanding, I love his quote. He says, the frontline healthcare workers, they add the final garnish to a lethal brew that has been long in the cooking. And so if you understand kind of like the system is set up to break down, right. And we rely on healthcare workers to kind of prevent that. Fixing that part of the system locally it really empowers people. I love that component.
Yeah, and it highlights also that all those high reliability principles, right? Your preoccupation with failure, right? Mm-hmm. So you're talking about it, you're doing something about it, deferring to the frontline worker to solve the problem, right? To their expertise. So it's really a way to incorporate a lot of those principles as well.
Yeah, as one final plug for learning from defects, I've seen it work very effectively in clinical and non-clinical work settings. There's nothing, clinical about figuring out a way to prevent recurrence of something bad from happening. So thank you, Pat. Let me turn back to Kyle for a second. Kyle, you already kind of addressed this a little bit in the chat. Do you mind if I just kind of re-ask it and you answer it for everyone here on the recording? About what can we do to make TeamSTEPPS sustainable? Because there's so many things going on. There's so much uncertainty. It seems like the uncertainty just won't stop happening. How do we keep TeamSTEPPS at the forefront, make it an enduring program?
No, I think that's perfect, because that's often the really important question. And I tried to address some of it in the chat, but I will say one of the things that evidence has shown that leadership continuity and leadership support really do help drive it to be sustainable. And as I came up with the title for this talk and I said, what's old is new, it was a little bit tongue in cheek around that, because you'll see a new leader come in and they want to do something new and different and sexy. And what's the new bright, shiny object that they want to lean into to leave their mark? And so sometimes what you want to do in that space is to not have TeamSTEPPS as this separate thing, this other entity living out there, but it's the means to the end. So yes, the leader wants to institute this new program. That's great. The way we're going to do that is with our TeamSTEPPS tools that are already ingrained. So I do want to add that to what was already in the chat. I will reiterate some of the things in the chat in terms of hardwire, make this part of the standard work. We want to really get everyone using SBAR. By every phone in the unit, we're going to print SBAR and what the reminder is. Every error report we're going to put in, it's going to be in SBAR format. Every email that's coming out from the leader is going to be in SBAR format. It's just going to be everywhere so that it becomes part of that work. When we have team member turnover, making sure to orient that next person coming on to these are some of the tools we use here. If you have a concern, we used I am concerned, I am uncomfortable, stop, this is a safety issue. This is how we bring that up. And so making sure they're oriented to those are some of the other things that you really want to make sure to do. Hardwire and make sure to orient new team members.
What a great example of kind of putting the S bar kind of next to every phone so that you're making it easy to do the right thing. That is such a, that echoes from so much of the work in the CUSP universe, where in order to reduce central line associated bloodstream infections, we first had to make sure everything you need was in a central line cart. The central line cart didn't exist until we realized you had to go to 12 different places just to do one central line. And so making it easy to do the right thing is, I think, a big part of making it sustainable.
Yeah, and I'll go back to the critical language. In our units, we have these little yellow things on our badges that are the CUS language. And I will have a nurse just hold up the yellow flag. They don't even have to say the words because it's something that we have practiced and are used to so much.
You bring up a great point, Kyle, right? And Brian, make it easy to do the right things. That's why we put things on the badge cards, right? The learn from a defect was there on the badge card to be able to just say, hey, I think we should. How do we prevent this from happening again? Why did it happen? And it's right there. The same with the scripts for interdisciplinary rounds. Make it easy to do the right thing. Have it right there. And the tool that I didn't talk about, but you talked about, Kyle, SBAR, I think is a phenomenal tool to improve communication and integrating and expecting it at another organization, University of Michigan, as we were adopting different tools. The SBAR became, you didn't, a leader, if you were going to request something from leadership, you put it in an SBAR. Give me an SBAR on that. And then it's incorporated into orientation. So if you're going to call a provider, that you need to use SBAR to do that. And the preceptors will look and teach and role model that that's how we use it. So a key tool to improve communication.
It's so remarkable to me how a little bit of structure goes a long way when you have a lack of predictability. It just reduces everyone's stress level enough that you notice. So that's awesome. I want to, I'd love to ask everyone a question here in a minute. So if I get you thinking about it, what is something about the work that you're currently doing that you're looking forward to, that you think is kind of what to expect 5-10 years out from now? But before you answer that, I want to take a question to Kyle. So I want y'all thinking about that, because I'll come to each of you kind of in turn here. But Kyle, I have just to make it more complicated on you. There's a question in the chat that is so ideal for you, given your experience and involvement in patient advisory work, and the question is, can you speak about how patient family advisory councils and other patient kind of advocacy groups can be leveraged to better advance safety in this way, using these tools that we know work? So how do we bring that into what we're talking about today?
Yeah, so thanks, Brian. That actually saves me a lot of typing, because I was getting ready to try to answer that in the chat. So multiple layers here. And it also hits on another question that I asked earlier of, can patients and families be taught to use these TeamSTEPPS tools? The answer is that absolutely yes. There's good evidence on that. Peter Napolitano out of UW Washington, he did work called Team Up, where it was specifically focused on families that way. So there's been multiple ways. CUS language we use. Teach the patient, I'm concerned, I'm uncomfortable, I'm scared. And we've used our patient and family advisory councils sometimes to help push that. In fact, we had probably, I want to say it maybe wasn't double digits, but high single digits, 6 or 8 of our patient family advisors go through our trainer course for TeamSTEPPS, where they could actually go out and help teach others TeamSTEPPS, and found that to be very valuable. In terms of how to really engage these patients and families through PFACs or other patient groups, some of the things that we learn in terms of lessons is, when you have that PFAC, does it sit separate from the work? And that's where I see a lot of hospitals work, is they have this council, that's their advisory council. People will develop their new protocol or policy, and then they'll have it all polished and they think it's ready to go. And then they bring it to the advisory council, and the advisory council says, yeah, that's great. Really, the person just wants a stamp of approval. But the advisory council says, here's 8 things you didn't think about of why this isn't going to work. And they have to start from scratch. And so we really were trying to lean in to pulling in advisors early in the work, not having this separate council, but let's have that patient family advisor on the actual work team, designing the work, getting that voice and input in early. And it's not only more effective, but it leads to better products and outcomes because they always have some aspect that we're not thinking about as providers because of where they're coming from. And in terms of prepping them to be part of that team, we taught them some of these skills, whether it be TeamSTEPPS, we taught them some of the lean management tools, train them as patient family advisors to be those partners who could have agency during the meetings to be able to speak up and really advocate.
So it's great, Kyle, that explanation. I think there's probably several hundred people at PCORI, the Patient-Centered Outcomes Research Institute, that are kind of applauding your answer to that question right now, because they're how to involve stakeholders at every level of these efforts. Well, real quick, let me start with Pat, and then I'll come back to you, Kyle, and Dave and Melissa. To say, given what we've talked about today with CUSP and TeamSTEPPS, given your knowledge of what's happening kind of in the field, is there anything that, as you think about it, you're looking forward to it, or you're anticipating something? What's the direction that this is heading that you can kind of like shine a light on for folks who are just getting introduced to this right now? Like, what is there to look forward to? So, Pat, do you think? Is that too esoteric of a question?
Yeah, it might be. So I think Kyle sums it up. What's old is new again. And I really think that we have to get back to our roots of what are the key ways to improve safety culture. And it's by programs like CUSP. It's by incorporating TeamSTEPPS, by applying the HRO principles. And I think that what's old is new again. I think we took a hiccup when COVID hit, and a lot of the work that was being done, everyone was in reaction mode, and then we get all new players as staff change. So I think it's about getting back to foundational work and programs. I don't think there's any new widget out there that's going to be any better. It's really just doing what we had started to do and getting it into our workflows, that it becomes just part of what we do.
That's totally fair. I just want to make sure I ask Melissa and Dave if you have anything, given what's on the horizon in the work that what y'all are seeing kind of at the national level. Is there anything that you want to kind of put on the radar of people who are thinking about CUSP right now?
Yeah, I think CUSP has always been a tool for empowerment of the front line, strengthening the team through that empowerment. I think that coming out of the pandemic with workforce strain and burnout, that empowerment and its connection with psychological safety are aspects that probably need renewed focus. In our new project, as we go to update our old toolkits, our subject matter experts are already on it. But that is an area that I'm excited about and we'll be looking to emphasize in the future.
Thank you. Thank you for that.
I totally agree with what Melissa said. And I would just add to that I think the exciting thing about CUSP and TeamSTEPPS is that even though it's what's old is new again, meaning that is a kind of a constantly appropriate and helpful approach to things, the science, the evidence behind patient safety, infection prevention is constantly evolving and improving.
Yes.
And making sure that we're using those processes and approaches that we have to incorporate the new effective strategies into practice, I think is something we can't forget. So we do have to bring the new into the old, if you will. And I think the new project that we're currently recruiting for that you discussed, Brian, and I think the link is in the chat to that website, that's going to help us use our CUSP approaches, TeamSTEPPS, whatever, to be able to implement some of the new evidence-based practices that may have come out and since people last thought about some of these HAIs. So really hoping people will incorporate those into practice.
That's such a great point, David. The science, the evidence just grows, which is beautiful. If we could put the last slide up, and Kyle, I wanted to kind of paraphrase your comment in the chat, which is one of the things that we can look forward to is how AI is going to fit into all this. I think it's a beautiful point. Like TBD, how that's going to work, but I think there's a lot of things to be excited about there. If we can go to the very last slide, one of the things that I want to just kind of end with is next month, we will be talking about our third session about how to measure and respond to your safety culture results across different healthcare work settings. Please join us there. Same bat time, same bat channel. Thank you for your attention. Thank you to all of our speakers today for answering these questions and spending this time with us. The recording will be on the website and all these wonderful resources we've been talking about as well. You can check that out on the AHRQ website as well. So with that, thanks everybody. We'll see you next month.